Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Cernăianu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. Welcome back, dear listener. What I would like to talk about in today's episode is a very specific skin condition that affects many women after menopause. This skin condition is defined and characterized by changes that happen on top of the changes that are already happening as a result of aging and loss of estrogen after menopause. This condition has a very possible autoimmune mechanism, even though it's not clear and it hasn't been demonstrated. There's a lot of controversy around whether this is an autoimmune condition or not. But the bottom line, this is defined by a chronic inflammation of the skin, which is creating a very specific pathological change of the skin at the vaginal canal entrance, which is called the vulva. And unfortunately, the reason why I decided to dedicate an episode to this topic is because these skin changes are underdiagnosed or misdiagnosed, and women are actually not treated at the time of the initial presentation. Sometimes they're not treated or mistreated for years. So there are many skin conditions that impact the opening of the vaginal canal, also known as the vulvar opening, and these conditions are very common after menopause. I talked about vaginal atrophy in the past ad nauseum. Vaginal atrophy is a very specific vaginal change which is happening to the skin of the vaginal opening and the vaginal canal due to the specific loss of estrogen. Once you give estrogen back to those tissues, you literally restore and rejuvenate and bring them back to the baseline. Obviously, not all estrogen is created equal. Providing steady estrogen levels 24 hours a day, 7 days a week will provide the fastest and the best improvement in vaginal atrophy. Whereas if you just decide to give someone estrogen twice a week, or this is how they prefer to receive it, at the very least, you can improve the symptoms due to the loss of estrogen. So again, vaginal atrophy is a very specific condition only created by the loss of estrogen. A rather commonly seen condition, estimated to impact anywhere from 1 in 1,000 to as high as 2 to 5 women in every 100 women, a condition that is manifesting mainly after menopause in the majority of cases, and in women specifically, is called lichen sclerosus. This is a skin condition which can be very debilitating outside of just causing painful sex. It can cause significant itching, often very intense and very persistent, which can be quite uncomfortable. It can cause smooth white patches on the skin in the genital and anal area. But what's the typical hallmark of this condition is the fact that the affected skin becomes thin or very significantly thinner and more pale, more fragile, and can tear easily with intercourse. Obviously, painful sex, possible pain with urination, sometimes pain with sitting for a prolonged period of time can be significant. There's sometimes pain with bowel movement, and they're very impactful for the quality of a woman's life. Most of the time, pain with burning, bowel movement, prolonged sitting, it's rare. It's in advanced, very scarring situations. Most of the time, most women present with painful sex. Just can't happen anymore. It's so painful. The most important and annoying thing about this condition is its capacity to scar and shrink the tissues of the vaginal canal opening, causing significant changes of the anatomy of the area. Like, for example, it can cause a fusion of the labia minora, the little lip, to the labia majora, the large lip, with a possible total disappearance of the labia minora. The same thing can happen to the clitoral tissues and the skin around the clitoris, called the periclitoral skin. And the skin hood can grow over the clitoris and it can fuse on top of the clitoris, leading to what we call complete hooding, where the clitoral erective tissue is no longer exposed during intercourse or stimulation and can be completely covered by the skin that normally is just a little bit above the clitoris. Also, the clitoris can shrink due to this condition, and this will significantly interfere with a woman's capacity to achieve a satisfactory orgasm. On top of all this, if this didn't sound bad enough, the skin can sometimes blister and erosions and fissures can happen, just like little tiny cracks in the skin. This will cause burning and irritation and pain. Now, since all these changes happen at the opening of the vaginal canal, the vulvar skin, the top number one presenting symptom always is significant sexual dysfunction with significant painful sex. But again, painful urination, painful bowel movements, painful skin in that area, like it just is uncomfortable to sit down for prolonged periods of time. Bike riding, horseback riding can also be presenting symptoms. This condition has been known and has been described since 1887, has been around for a while. What you need to know about this condition is that it's a chronically relapsing condition with a significant potential for atrophy, thinning, and this sounds just like about the vaginal atrophy, right? It's thin and atrophic. But on top of that, it can cause destructive scarring, which is causing functional impairment, and it can increase the chance of vulvar cancer. So obviously, early diagnosis, prompt treatment, and long-term follow-up is absolutely necessary for this specific condition. The most important component and what makes this condition so difficult to treat and gives its main symptom of painful sex is the inflammatory and the destructive scarring mechanism of presentation. Again, it's also known as lichen sclerosus and atrophicus. So it's thinning, scarring, narrowing, shrinking. Doesn't sound good, right? The cause of this condition is unknown, but apparently there's a genetic susceptibility to it, and it's more prevalent, much more prevalent in female patients. But we can also find it in male patients. It can actually affect their penis as well. Now, unlike the thinning caused by aging atrophy and its immediate reversal with estrogen, once the skin of the vaginal opening has been scarred due to the scarring process of lichen sclerosus, when you give a woman estrogen, it will not necessarily reverse the process, especially vaginal estrogen. What is worse is that this is a chronic progressive condition. It is lifelong, and it's also sometimes relapsing, but sometimes can be in remission. If you're going to ask, well, what would cause this to relapse once we treated it and everything's hanky-dory and peachy? Well, I'm pretty sure stress. It can have a profound impact on the immune system, so it definitely plays a role. So a relapse can be triggered by stress, any stress. So how do you live a non-stressful life? Well, that will be the topic of a self-help podcast episode, but not today. What I want to tell you and what you should know, and this is pretty well known in the medical world about lichen sclerosus in adult women, is that it can cause significant alterations of the vulvar architecture. Now, the top and most serious problem, which I mentioned already, is that the clitoris can be trapped under the scar tissue of the skin that's covering it, called the hood, which can fuse over the clitoris, causing clitoral hooding. Again, The clitoris is completely covered by the skin, so the erectile tissue and the sensitive, full of receptor tissue of the clitoris will be covered by the skin completely, so not accessible for stimulation during intercourse. And the other big problem with the architectural changes, and that's not really bothering many women because they don't even notice it until the doctor looks down there and they're like, wait, you don't have labia minora anymore, is the disappearance of the labia minora, the shrinkage. The smaller vaginal lips will shrink to the point of complete disappearance. They can fuse to the skin next to them. You can see where they used to be separated. There's like a little line between them. And the worst problem with this condition is that due to the continued unaddressed process of scarring, the vaginal opening may become very narrowed and what we call in medical world stenotic. It is disappointing, frustrating, and sometimes shocking for many women to find out that they've been going to their gynecologist or primary care doctor or whoever they've been seeing, their faithful mid-level provider that they've made a very good relationship with, and find out that they were never diagnosed. They were never told that they might have a vulvar skin condition that is progressive, that is causing progressive scarring of the tissues at the entrance of the vagina, leading to painful and impossible penetration if not treated. What I've noticed is that many women, when confronted with a new diagnosis, the first thing they do is they think back on all the years they've suffered from the symptoms, which didn't happen 3 months before they come to me. They usually happen 3 years or over 10 years before the moment they come to me, and wonder why their previous doctors or providers did not diagnose them. I've seen that time and again, such women focus on the negative when told they have a skin condition like lichen sclerosus. The disappointment and sometimes the real anger they feel as to why they weren't told before or treated before can actually supersede any positive thoughts related to the fact that, hey, we have a diagnosis now. We know what to do, and we have solutions which can provide meaningful help and improvement. I do not mean to blame the physicians or the providers who did not diagnose these women early enough, because the typical changes encountered with this possible autoimmune but definitely chronic inflammatory skin condition in the form of white plaquing or the severe shrinking of the tissues to the point of almost complete stenosis are not always or usually present. As a matter of fact, from my experience, 60 to 70% of biopsies which confirm lichen sclerosus I have made for patients who present with subtle changes, which means I diagnosed them very early before it even became obvious. So because this condition affects women of all ages, but in reality, 90% of women are after the age of 50. Again, 90% of women who get this condition are after the age of 50. Lichen sclerosus gets confused with the atrophic changes caused by the loss of estrogen that is happening during and after menopause. It is very easy to mistake the thinning of the tissues at the entrance of the vaginal canal for the menopausal atrophy, which normally happens when women no longer have estrogen. So don't blame your doctor or your provider. If they're not experienced in vulvar skin conditions, they would not pick this up early enough. To them, it will look like atrophy from menopause. You might get recommended vaginal estrogen, which just a couple of words here. Vaginal estrogen will never work for a vulvar skin condition, especially in the form of a vaginal insert tablet that you insert twice a week that will treat the vaginal canal. This specific skin condition, lichen sclerosus, does not affect the skin of the vaginal canal. It affects the outside skin, the vulvar skin. So unless whatever topical treatment you're going to use is going to mean rubbing daily or twice a day, a solution, an ointment, a cream with something to impact the progress and the inflammatory changes of this condition, you are not treating this condition, lichen sclerosus, with vaginal estrogen. Now, coming back to the atrophy, the reason why lichen sclerosus is mistaken for atrophy from menopause is because atrophy can happen even if and when women use estrogen replacement. You're going to say, wait a minute, really? I can have atrophy even though I use estrogen? Yes. The estrogen replacement could be an actual very small replacement compared to what you used to have before menopause. So atrophy can still happen and can still cause symptoms, even if a woman is using a patch, a gel, a cream, even with belotherapy if it's low dosed enough. So what I'm trying to say and what I would like for you to take from this is that lichen sclerosus is a very serious condition. It can be easily confused with the changes due to menopause, both by the patient and by the doctor. And I'm going to repeat this again because it's the key message of this podcast. Lichen sclerosus can be easily confused with the vaginal atrophy that's happening during and after menopause, both by the doctor and by the patient. The patient believes it is aging and the dryness is normal because they are getting older and they don't have estrogen. And the doctor believes it's just the loss of estrogen. And the changes they see is because there's less estrogen, so there's going to be thinner, paler, less moist, shrinking down tissues. Again, the doctor who prescribes vaginal estrogen for a vulvar skin condition, that's not going to work. Many women use first line of therapy, which I mentioned in my previous podcast episode, lubrication adjuvants. And they keep doing that to address the dryness. So they don't know that they have a problem. They just think, oh, it's menopause. So they keep using lubricants until the lubricants fail to help them because their relief will actually be temporary. The sex will become too painful, and then they just simply stop having vaginal sex. So any physician, specifically a gynecology physician, should be able to recognize advanced stages of lichen sclerosus. Any physician, even the general primary care doctor, should be able to recognize the white plaques that are typical of this condition. However, it will take a more experienced eye to see the changes that will happen at the beginning of lichen sclerosus, especially if it's happening in a menopausal patient, in order to correctly diagnose the condition and properly treat it. So how do we diagnose it? Well, we need a skin biopsy. A skin biopsy of the vaginal skin of the entrance of the vaginal canal, of the vulvar skin. It's very simple. And it needs to be done properly with a very good topical anesthetic. We like BLT, benzocaine, lidocaine, tetracaine. I apply the numbing medicine in the area that I want to do the biopsy. It's a very small area, targeted, where you see the problem. I let the woman numb for about at least 15 minutes. Once the numbing is done, I inject a little 1% lidocaine with an insulin syringe at a very tiny needle, which now that they have the BLT on top of the skin, they don't feel anything. And then it's a simple biopsy that literally once we start, it takes 2 minutes to complete. The results will come back in 7 to 10 business days. And what I want you to know is a very useful trick that I learned from personal experience. Your doctor needs to tell the pathologist what they are looking for. Why? Well, let me tell you. When I was 100% sure this is lichen sclerosus based on what I saw, the biopsy would come back with some detailed description of inflammatory infiltrate of the dermis with edema and other blah, blah, blah derm language. So I had to pick up the phone, talk to the pathologist, and I would tell the pathologist, hey, is this lichen sclerosus? Because I'm pretty sure this patient has lichen sclerosus. So they would immediately say, oh yeah, you see these changes in lichen sclerosus. That's probably what this is. So then I would immediately ask them, hey, why don't you say that this is lichen sclerosus? And they said, well, we don't know that that's what you're looking for. So you got to tell us that's what you are looking for. Otherwise, we're simply going to describe the findings. So they would always reissue the report with a revision. And there will be an addendum that changes seen are consistent with lichen sclerosus. So now all my pathology requests, when I do a vulvar skin biopsy, when I suspect lichen sclerosus, very clearly state, please rule out lichen sclerosus. And it needs to say that because otherwise the doctor is going to read the report and it's going to say, oh, it's benign. It's just some inflammation. If your doctor is not familiar with the description of lichen sclerosus pathology changes, this will get missed. So if you find yourself in a situation where the symptoms match how this condition manifests, please make sure to ask your physician for this simple test, a vulvar biopsy, and then add on the pathology request form, rule out lichen sclerosus. Again, what are the symptoms? Most of the women with white plaques have a lot of itching and a lot of symptoms of irritation. The itching, it's a burny itch. It's not a pleasant itch. And they might also have the sensation of burning and discomfort with sitting, and especially when they wear tight pants. Obviously, bicycling, sitting in a saddle will be very uncomfortable. But the key symptom of this condition is painful sex. Sometimes there are very specific things or descriptions that accompany the painful sex. So it's important to ask a woman, how is the sex uncomfortable? Is the sex uncomfortable at the beginning? Is it at the entrance? Is it deeper in? What does it feel like? Because sometimes you hear very specific instructions that can guide you as to what's really happening. Like, well, sex is hard to get started, but once we start, it's easier to get going. Or you might hear something like, I'm tearing every time we have sex. It burns afterwards for a few days, and it's making it very difficult for me to want to have sex. Or you might hear a woman say, it feels like ground glass down there. Or it feels like sandpaper. Or they might say, it feels like ripping. It feels like something is tearing me up. There could be many reasons why a woman has painful sex. But when the discomfort with the act of penetration occurs at the beginning of the sexual penetration, that is a clear sign that the skin at the entrance of the vaginal canal is suffering abnormal changes. There are many skin disorders that impact the skin down there and create inflammation, which will ultimately lead to thinning or thickening or scarring. And all of these conditions are accompanied by dryness with a significant lack of lubrication, and the scarring can have significant limitation and can seriously hinder the act of sexual penetration. What used to be easy and comfortable gradually becomes more and more uncomfortable to the point where the woman has to say, no, this is not going to happen. It hurts too much. It is very sad to have to consult and assist women who come to me because they stopped having sex years ago due to discomfort. It is also sad that many of these women were told by previous physicians that it's simply happening due to the loss of estrogen. And they were not counseled on the benefits of appropriate estrogen therapy, whether topical or systemic, and what the benefits of such therapy would be for sexual wellness in a manner that will allow them a fully informed decision. They were not given the options for testosterone treatment. They were not told that steroids could help. They were not told about immunomodulators. They were not told about peptides. They were not told about PRP. They were not told about laser therapy. So they waited and waited and waited until a friend, an acquaintance, or prolonged research online prompted them to decide to get a second opinion and send them my way or on the way of another physician that is experienced in these conditions like myself. And you don't have to be very experienced. Sometimes you just see something, you're like, okay, this doesn't look okay. Can I take a biopsy? It's very simple. It's very easy. It's paid for by your insurance plan, and we will get a decision. Telling a woman to simply use a lubricant is not good enough, and it should be considered substandard, subpar medical care. The sexual well-being of a woman is very important to her, even though she's not necessarily presenting sexual discomfort as a main issue of concern. Maybe because of embarrassment, of shame, fear of being told there's nothing that can be done, fear of disappointment, just another disappointment, or maybe she's just become comfortable with the situation as it is and has given up on the whole idea of being intimate with a partner. Whatever the reason may be, the truth is many women do not engage with their provider when it comes to sexual dysfunction. On the other side, providers are not interested in opening the conversation because, let's be honest, you need time. And once you have the time, that's beautiful. But if you're using an insurance plan, all this conversation is not going to be rewarded in any way, shape, or form. It's just going to detract from the main subject of the visit, and it's going to create a complication. Also, the majority of the providers are completely lacking in any kind of education around this subject. And if all you have to do is offer over-the-counter lubrication or some vaginal estrogen, you might as well not even address the issue because you are under-equipped to address the problem. So it really does matter why there is vaginal dryness. And my message with this podcast episode is not to assume your vaginal dryness is because of age or because your hormones are low or because you're not getting aroused as you used to. As human beings, we love rationalizing. We love explaining discomfort and uncomfortable changes that happen in our body. We love finding a reason and already having justified it in our minds with a cause. This is a coping mechanism. But when it comes to vaginal dryness, yes, it could be a sign of a relationship difficulty, loss of desire, lack of arousal. It could mean low hormones, low estrogen, low testosterone. It could mean that you are simply aging, but doing nothing about it will not solve the problem. Using a lubricant to improve the dryness and allow the act of intimacy is a great solution, but it's a temporary solution. Please have a consultation with a doctor who is experienced in sexual dysfunction or abnormal skin conditions of the vaginal canal entrance, who can do an appropriate assessment and give you a proper diagnosis and an actionable treatment plan that would fit your goals, your desires, and ultimately your budget. When confronted with a diagnosis of lichen sclerosus, many women react with fear, frustration, disappointment, anger, a lot of different negative emotions, which unfortunately makes a lot of them unreceptive to the treatment plan. All they focus on is, how come no other doctor has told me this? Well, again, I said it's not necessarily the doctor's fault because to diagnose subtle early changes, you need experience and you need to have total and absolute familiarity with what the vaginal skin at the entrance of your vaginal canal should look like. That means you probably need to be a physician or a specialist who has seen a great variety of patients and has examined a great variety of conditions and abnormalities of the vaginal skin at the entrance of the vaginal canal in order to be able to pick up and detect early an autoimmune inflammatory condition like lichen sclerosus. If your gynecologist is a very busy obstetrician, it's very possible that the type of practice he or she has is less shifted to menopause care and more shifted to obstetrics. You can't really do both very well. There are many doctors like me who understand that in order to provide top quality gynecology services, you need to be available 8 hours a day in your office to properly manage gynecological and aging issues for women. Additional training on top of all this, additional training is required in the field of hormone therapy and in the field of sexual dysfunction, as well as keeping up to date with the most recent trends or updates for standard of care and recommendations for a variety of gynecological conditions. And that's why many OBGYNs lack additional training. So don't be afraid to ask questions, which will allow you to gauge a doctor's experience. Maybe just ask, how many patients a year do you diagnose and treat that have this condition? And then listen carefully and ask questions about the proposed treatment plan. If all you are offered is a steroid, which is unfortunately standard of care, I'll talk more about this next week, then by all means, look for a second opinion physician who can give you more options because there are more options. And I apologize for leaving you in suspense a little bit until next week when I come back with the treatment options for this condition. And I discuss the pros and the cons, what applies to lichen sclerosus. And all of these principles do apply to many very interesting conditions of the vulva, the opening of the vaginal canal. So if you have painful sex, vaginal dryness, changes in the anatomy down there, any kind of interesting discomfort, please make sure to visit a physician who specializes in gynecological skin conditions of the vaginal opening, because they will be able to help you. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.